All right, we'll get started now that it's 1:30. Hi, everyone. Welcome to the Understanding Non-Motor Symptoms of Parkinson's Disease webinar with Dr. Lee. My name is Emma Tornero, and I'm a Client Service Coordinator with Parkinson Association of Alberta, and I'll be moderating this webinar. If you have any questions during the webinar, please submit them in the chat below. I'll get the chat started, but if you go to the bottom menu on your screen, you'll see a little chat blurb icon. You can click that. It will open the chat for you, and you can type in your questions. If you choose to, at the end, you're able to unmute yourself and ask the questions directly that way as well. And your questions will be sent to all of the panelists and to the group. Just a disclaimer, this webinar will be recorded and all the information provided in the videos by Parkinson Association of Alberta and our featured speaker is furnished strictly for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, care, and/or advice of your healthcare team. General questions about symptoms, treatment, available medication, complementary or alternative healthcare therapies, and current research will be fielded. Today, we are excited to welcome Dr. Joyce Lee, who founded and led the first geriatric Parkinson's program in Canada at North York General Hospital in Toronto from 2007 to 2021. She specializes in comprehensive geriatric assessment for older adults with Parkinson's disease, addressing their motor, non-motor symptoms, polypharmacy, and comorbidities. She started with the Geriatric Parkinson's Assessment Program and the Parkinson Movement Disorder Program at the University of Alberta in 2022, and currently serves as the co-director of the Parkinson Foundation Center of Excellence. Dr. Lee is passionate about empowering and educating primary care providers and their teams to bring high-quality Parkinson's care to more communities in Alberta and beyond. Dr. Lee, we're very excited to have you and for all the care that you're doing for our Parkinson's team. So I'll hand it off to you now.
Thank you, Emma. I'm wondering if you can see my slide properly now.
I can see it. It is not in the full presenter mode, but we can see the slides.
Okay. Is that okay? Because I realized that the other one that I was sharing was not exactly the right one. Anyways, okay. So, let's just do this. I'm really happy to be here with you today, and we're going to talk about the non-motor symptoms of Parkinson's disease. So today we're going to talk about the common non-movement or non-motor symptoms of Parkinson's and the strategies to deal with some of these symptoms. So this is probably a bit of a review for most of you, because I'm sure you have been to webinars before where people have discussed the brain changes in Parkinson's disease. So essentially what happens in Parkinson's is that there's a loss of dopamine producing brain cells in the substantia nigra, which is part of the basal ganglia. And these brain cells, generally, they are used to control movement. And when the motor symptoms or movement symptoms of Parkinson's start to appear in most patients, over 50% of these dopamine-making brain cells are already lost. The underlying pathology of what is happening is that there is a protein called alpha-synuclein, which is, excuse me, just one second, close the door. So the alpha-synuclein is a protein that gets misfolded in Parkinson's disease, and it forms these little things that we call Lewy bodies. And when these clumps of protein accumulate in the nerve cells, it leads to the nerve cell damage and loss. Now, for most people, when they think about Parkinson's disease, they think of the movement symptoms, which is the slowness, the stiffness, the postural instability, tremor, and so forth. But actually, that is only the tip of the iceberg. Parkinson's disease, the pathology, the pathological changes with the Lewy bodies in the nerve cells actually is spread way beyond the substantia nigra. It goes into other parts of the brain, other parts of the spinal cord, as well as our peripheral nervous system. And that gives rise to a lot of these so-called non-movement or non-motor symptoms, which we're going to talk about today. So how common are these so-called non-motor symptoms? It turns out that in early Parkinson's disease already, a lot of people, up to 97%, actually already have a reduced or change in smell or taste. Fatigue is very common in 60%. Depression can be present in 25% of patients, and constipation in 30%. REM sleep disorder, which is when people act out their dreams, can be present in 30% of patients, sometimes for up to 2 decades before the onset of the physical motor symptoms. And in late stage, these non-motor symptoms become even more common. You can see that constipation can be present in 80 to 90% of patients, postural drop in blood pressure, urinary symptoms, freezing and falls and swallowing dysfunction, as well as cognitive impairment. So why do we even care about non-motor symptoms? Well, by looking at the list, you can imagine, and probably from personal experience for those of you here who have Parkinson's disease, that these symptoms really, really impact people's quality of life and function. And it is most often underdiagnosed and undertreated in routine neurology assessments. It can lead to significant caregiver burden and also increase the risk of people going to hospital and poor health outcomes. So before I came to Edmonton, I was working in Toronto, as Emma mentioned, and I ran a geriatric Parkinson's clinic there. We did a study there looking at phone calls that people made to the clinic. And it turns out that most of the phone calls, as you can see in this pie chart here, are because of non-motor symptoms. And motor symptoms are actually the minority of the reason for the phone calls. So when I teach people about Parkinson's, our residents and students, I always teach them that when we talk about Parkinson's disease, we have to think about the comprehensive assessment, which includes motor, autonomic, and neuropsychiatric/sleep. So an acronym for that is MAN, MAN. Today, we're going to talk about primarily the autonomic nervous system. So the autonomic nervous system is the system throughout our peripheral nervous system that governs all the things that we don't actually think about. These are things such as breathing, your heart beating, your digestion. So you can see that there's a very complex array of nerves that go through the entire body that governs all these things without us even thinking about it. And the autonomic nervous system, when the Lewy bodies, which is the underlying pathology of Parkinson's disease, spread through these nerves, it can give rise to a lot of those non-motor symptoms, including constipation, bladder dysfunction, postural drops in blood pressure, and so on and so forth. So what are some of the autonomic symptoms of Parkinson's? As I mentioned, there's the blood pressure, there's so-called orthostatic hypotension, which is defined as a drop in your blood pressure upon lying or standing to sitting position change. So when you go from lying or sitting to standing, your blood pressure is supposed to be maintained. But in Parkinson's disease, when there's autonomic dysfunction, that does not necessarily happen. Gastrointestinal symptoms, including slowed down stomach emptying, which can also increase the chance of having acid reflux. Constipation, as small bowel bacterial overgrowth, are some of the gastrointestinal symptoms of Parkinson's. Urinary symptoms, including so-called overactive bladder symptoms with urinary urge and frequency, is quite common. Sexual dysfunction, and thermal dysregulation, which is the trouble with body temperature regulation, which can lead to sweating episodes. So let's focus for a minute on the gastrointestinal tract in Parkinson's. It turns out that these alpha-synuclein Lewy bodies structures are found throughout the gastrointestinal tract for even up to 15 years before the onset of movement symptoms. And in the case series, constipation could be present for up to 15 years before the onset of the Parkinson's movement symptoms. Constipation is honestly one of my favorite topics because it is so simple, but it is really serious in Parkinson's. It can lead to a lot of poor health outcomes and a lot of problems for people. Now imagine if you're constipated and everything is kind of, not moving along and blocked up, right? Then you're not going to feel like eating and drinking very well. So therefore, people can actually lose weight and have poor oral intake and dehydration from constipation. It can lead to poor levodopa absorption and much worse motor symptoms and fluctuations. It can even lead to urinary retention, meaning that basically your urine cannot leave the bladder. Okay, you can't pee, and people end up in hospital for that. It can cause delirium, which is acute confusion. And I've seen people have delirium not because of anything else, not because of an infection or anything else, but just because of constipation. So as you can see on the left there, we've got the Bristol stool chart, which shows you exactly the sort of morphology of the stool. And what we want to do is we want to have a type 3 to 4 soft stool at least every day or every other day, because otherwise your levodopa is not going to absorb properly. So now I just want to show you why it can lead to urinary retention. So you can see the structure. The rectum is sort of the thing that is closest to the spinal column on the right side of each picture. And then there is the bladder in front. And you can see that when you look at it this way, this is a person cut from sort of the side, it is actually very close to each other. So if you imagine that there is a lot of stool, hard stool inside the rectum, it can actually block the exit of urine. And I can tell you that based on my many years of doing geriatric medicine in the hospital, very often when people end up in urinary retention and they can't pee and people have to put a catheter into them, at least one of the contributing factors is constipation. So when we talk about constipation, we have to think, about what are the mechanics and what are the necessary ingredients for having a good stool. You need good texture, good motility, as well as core strength. Okay, so the texture has to be soft enough that it's not rock hard, because that would be very difficult to pass. Motility, so your gut, your intestine have to be, motile and moving, having that sort of wave-like peristalsis in order to move the stool out. And unfortunately, in Parkinson's disease, when the Lewy bodies have invaded the nerve cells around the gut, very often the motility is slowed down in Parkinson's. And core strength, of course, is when you need to have some strength in your core, in your abdomen, to push the stool out. So when we talk about treatment of constipation, of course, in general, we talk about increasing the amount of fluids, fiber, and exercise, which can help with constipation. So when we talk about improving texture, Restoralax or Clearlax, or there are some other brand names, Laxaday. In essence, what that is polyethylene glycol 350, and that medication is probably the most evidence-based one for Parkinson's disease-related constipation. What it does is it improves the softness or the texture of the stool. So it's not even really absorbed. There are a lot of sort of, I guess, myths around PEG, and people are like, oh, it's like, not natural, it's a chemical and blah, blah, blah. But actually it is very safe. I can tell you that even children take it. My daughter used to take PEG a lot because lots of kids have constipation. And what PEG does is it basically just, you take it with water, and it draws water into the colon to soften up the stool and create some bulk. And in general, for Parkinson's patients with less motility in their gut, I don't recommend psyllium or Metamucil because you need a lot of water for Metamucil to work, and you also need good motility in your gut. And if you don't have good motility in your gut, which is a lot of the cases in Parkinson's disease, then it's not really going to work for you. It would just harden up the stool and may even make it harder than before to pass. Now, to improve motility, because as I mentioned, in Parkinson's, constipation, the motility is often a huge issue. Exercise and abdominal massage, those kinds of things can improve the motility. And if just taking the Restorelax and doing exercise is not enough to give you a bowel movement every day or at least every other day, then stimulants such as Senokot or Senosides or Bisacodil, those should actually be prescribed more regularly to overcome that problem. Because if you only use Restorelax or PEG, it softens the stool. It doesn't necessarily give your bowels the stimulation, the oomph to move the stool out. And eventually, if you don't move the stool out, it's just going to sit in there and you're no further ahead. So there's some data showing that probiotics may improve constipation in Parkinson's as well. Now, whether that is, through improving the motility or a change in the microbiome, we're not quite sure, but the research is still ongoing. So next, we're going to move on to the cardiovascular system in Parkinson's disease. So just as with the gastrointestinal system, these alpha-synuclein-formed Lewy bodies are also found in the nerves, which can regulate heart rate and blood pressure. And because of that, of the presence of these Lewy bodies making these nerves not function as well, it can lead to what we call orthostatic hypotension or postural hypotension, which is defined as a drop of 20 millimeters mercury in systolic blood pressure and or 10 millimeters mercury in diastolic blood pressure when people go from lying to standing. So if we look at those pictures down below, when someone goes from lying to standing, the normal autonomic nervous response would be for the body to increase the heart rate or the pulse and how strong the heart is pumping to maintain the blood pressure. But when there is this sort of autonomic dysfunction in Parkinson's, what happens when people go from lying to standing or from sitting to standing is that the heart rate doesn't increase sufficiently and the heart pumping stronger does not increase sufficiently either. So your blood pressure ends up dropping. And this results in that drop in blood pressure when you have a position change, which is called orthostatic hypotension. Now, a correlate of that is postprandial hypotension, which means you can drop your blood pressure after you eat, especially if you have a big meal. So how does that happen? When you have a big meal, the blood gets pulled to the gut, to your digestive system to digest the food, and it can actually lead to a drop in blood pressure. So for some patients with, significant issues with this orthostatic hypotension, they can also have drops in blood pressure after eating, and they can even pass out in their chair. In 50% of people with orthostatic hypotension, they can also have something called supine hypertension, which is high blood pressure lying down. The other interesting thing about this kind of cardiovascular change in Parkinson's is that for most people, our blood pressure drops when we're sleeping at night. But for Parkinson's patients with this problem, oftentimes the blood pressure actually goes up in the evening and rises when they're lying down at night, which in and of itself can present a few problems. It can lead to higher risk of cardiovascular disease, strokes, because the blood pressure lying down, of course, when it's very high, can also lead to those consequences. And it can also lead to people producing more urine at night and urinating more often. So what are some lifestyle or non-drug treatments that we can use for orthostatic hypotension? Raising the head of the bed by 4 to 6 inches, drinking more fluids, of course, increasing salt intake, and I like recommending having a cup of V8 or salty broth at breakfast and lunch for my patients. And before you get out of bed or get up from a chair after sitting for a while, you should try and drink a glass of fluid before getting up. And pumping your legs will also help. So abdominal binder, okay, is as opposed to compression stockings, would be my preference for treating orthostatic hypotension. Essentially, what an abdominal binder is, you can see that in the picture on the lower right corner of the slide there. If you put it on before you get up for the day, then what it does is it's kind of like an elastic girdle. It compresses your gut and compresses the blood and returns the blood which is pooling in all the blood vessels around your digestive system back to the heart, okay? And it helps to stabilize your blood pressure when you stand up. And the way to use the abdominal binder is you put it on before you get up for the day, and you simply take it off at bedtime. I prefer this to compression stockings because I don't know if anybody has tried compression stockings, but they tend to be very difficult to put on. And compression stockings really only work if it goes up to the waist, meaning you need that abdominal compression because a lot of the blood that is pooling in the veins are actually around your digestive system as opposed to in your legs. So it's compression of the abdomen that is most important in these cases. Strengthening your leg muscles using resistance bands or weights, doing squats, etc., and pumping them before getting up can also help to some degree, pumping that blood back into your heart and eating smaller frequent meals. As I mentioned earlier, if you eat a massive meal, a lot of the blood goes to your digestive system, and that can also increase your risk of low blood pressure. Now, if all these lifestyle measures are not sufficient, then your doctor may decide to prescribe some medication for you. And the choices are midodrine, which essentially squeezes the blood vessels to increase blood pressure. It has to be taken 2 to 3 times daily. The thing about midodrine is that the effect only lasts about 3 to 4 hours, and it is important that you don't lie down flat for 4 hours afterwards because of the fact that it squeezes the blood vessels to increase the blood pressure. If you lie down during those 4 hours, it can increase your chance of having significant high blood pressure. Fludrocortisone is a medication that helps the kidneys retain salt and fluid to boost blood pressure. And pyridostigmine mildly increases blood pressure upon standing, but it does not have the danger of increasing the lying down blood pressure. And as well as I mentioned before, because 50% of patients with orthostatic hypotension can also have that high blood pressure overnight while they're lying down, treatment of the high blood pressure overnight can help reduce the urine output and the resultant dehydration and low blood pressure in the morning as well. So now let's move on to some other non-motor symptoms. Overactive bladder, which can manifest often as urinary frequency and urge. There are some things that can worsen it. Some medications can worsen it, such as donepezil and other cholinesterase inhibitors. Caffeine can certainly worsen it as well. So if this is something that you're suffering from, you might want to cut down on your caffeine intake. The management. First of all, you need to treat constipation. Because if you don't treat the constipation aggressively, as I have shown you before, then the heart stool and the rectum can block the exit of the urine. And because then your bladder wouldn't be empty every time you urinate, you will end up having to urinate more frequently. And other lifestyle strategies include timed urination, as I mentioned, avoiding caffeine. So timed urination is basically, you try to go to the bathroom every 90 minutes or every 2 hours. Basically go and empty your bladder as well as you can before you have the severe urge, because you don't want to wait till that significant urge because you may or may not make it at that point. Drinking most of the fluids before 7 p.m. so that you don't have the overnight symptoms of having to pee multiple times. And if you do need to pee overnight, then consider the safety options. There's the options of using a commode, a urinal, etc. And there are, of course, some drugs that we can use also for overactive bladder, which include mirabegron, physotieridine, and solifenacin. In general, these are considered to be quite safe for Parkinson's patients, even for people with some cognitive issues. For the older drugs, such as oxybutynin, we tend to say no to those because they can result in too many side effects, including confusion, significant dry mouth, even worsening of constipation, etc. Now let's move on to the neuropsychiatric symptoms of Parkinson's. These include several things, including mood issues such as depression, anxiety that can affect about 50% of patients with Parkinson's, fatigue, which can be present in about 60% of people with Parkinson's, and sleep problems, which can include REM behavior disorder, which is having vivid dreams and acting out dreams, restless leg syndrome. As well, we're going to talk about a bit about cognitive impairment, dementia, and hallucinations. So in terms of fatigue, it affects 60% of patients. The strategies, include exercise, addressing any sleep issues and any mood issues, and optimizing levodopa dosing. Beyond that, there are some studies on certain medications, but we tend to recommend these sort of non-drug strategies before trying any medication for it. Next, we're going to talk about REM sleep disorder. And REM sleep disorder is one of the most common sleep disorders in Parkinson's, and it can be actually present in patients even up to a couple of decades before the onset of the physical movement symptoms. So what it is that during REM sleep, which is when we're dreaming, our large muscles are supposed to be paralyzed so that we don't end up acting out our dreams, right? So let's say we're dreaming that we're running away from a lion or something. Our muscles are not supposed to allow us to do that. We're supposed to stay in bed, right? However, in Parkinson's disease, there is often an incomplete paralysis of those big muscles, and people end up yelling and acting out dreams during the dream stage. And this can result in, people punching their bed partner, kicking in their sleep. People can even get out of bed, fall out of bed. It can be quite a safety issue for some people. And the first thing we do is that we need to review the medications on your list if you're having REM sleep disorder. Certain medications, particularly antidepressants, can worsen REM sleep behavior disorder, so we recommend that they be taken earlier in the day, such as at breakfast or lunch, so as not to worsen the sleep phenomenon. Melatonin extended release or dual action before bed can help quite a bit. And if that is not sufficient, your doctor may prescribe something else called clonazepam. Restless leg syndrome is a sensation of numbness, tingling, or discomfort in the legs, or can be other parts of the body as well, with an urge to move. Movement usually relieves that discomfort. And in Parkinson's disease, this often indicates a kind of wearing off of your levodopa. So in general, when people complain of restless legs, we adjust the levodopa or Parkinson's medications at bedtime for them. Because as I mentioned, it's usually correlated with the medication wearing off. If there are other issues such as iron deficiency that is also contributing to the restless legs, that needs to be treated. There are other physical modalities that can be helpful, such as cold packs, stretching, exercise, and hot packs for some people. And if, just adjusting levodopa is not sufficient, sometimes your doctor may prescribe other medications such as gabapentin for this. And now let's move on to mood, anxiety, and cognition. Now it is beyond we don't have enough time to go into a lot of these things today in detail, but I just wanted to mention that there are some non-pharmacological ways to really improve your symptoms. The MIND diet, which we're going to go through in the next slide, and the Mediterranean diet has been shown to reduce the risk of and can delay onset of Parkinson's disease, possibly through the modification of the microbiome. And in particular, the MIND diet, more than the Mediterranean diet, can reduce multiple non-motor symptoms in Parkinson's. Now, if you think about the MIND diet, which we're going to see on the next slide, it makes sense that it would improve things like constipation. However, what is fascinating is that this diet also improves other non-motor symptoms that are very hard to treat, like motivation, depression, anxiety, fatigue, daytime sleepiness, etc., etc. So I find that to be very, very interesting. So what is the MIND diet? Essentially, the MIND diet is the Mediterranean diet plus the DASH diet, which is basically a low sodium diet that is for hypertension. So avoiding limiting sweets, pastries, red meat, cheese, butter, margarine, etc. Now, the caveat with this is that for those people who have orthostatic hypotension, as I mentioned earlier, they need to actually have more salt, not less. So that is the only caveat with this diet. But mainly, this kind of diet includes whole grains. So, really avoid the white carbs, lots of dark green leafy vegetables, berries, nuts, beans, and legumes. The protein source has to mainly come from poultry and fish. And in general, we don't recommend wine anymore because this is, in the old days, people used to recommend some wine, but we generally don't do that anymore because there is now evidence that alcohol actually is not, the risk actually outweigh the benefits. And generally avoiding those sweets and red meat and cheese and pastries and so forth. The other thing that is really, really important for Parkinson's in terms of non-motor symptoms is actually exercise. So different types of exercise can have different benefits. And aerobic exercise in particular is shown to improve motor function, cognitive processing, mood, and quality of life. And there's even recent data that moderate to high intensity exercise can delay the progression of the motor symptoms of Parkinson's disease, especially in early Parkinson's. For people who are not even on levodopa yet, when they go through high intensity exercise for at least 150 minutes a week, in 6 months, the motor symptoms have not progressed in the study. Resistance training can improve muscle strength, motor function, endurance, and sleep. And things like yoga, dance, qigong, the type of things that we think of as mind-body exercise can benefit sleep, flexibility, well-being, and anxiety. So exercise and neuroplasticity. I know that neuroplasticity is something that a lot of people think about and want to talk about these days. And one of the ways, neuroplasticity essentially is the idea that our nerves and our brain can actually be changed by our experience and what is exposed to. So there is evidence that exercise increases brain-derived neurotrophic factor, BDNF, which is something that can protect our nerve cells and help it to regenerate. So there's evidence in animal studies that exercise can increase BDNF, and which can support the neuron protection and regeneration. Exercise has been shown to reduce neuronal inflammation in animal models, and we know that inflammation may be part of the problem in some of these neurodegenerative diseases. And there's evidence in Parkinson's disease in functional MRI that after high intensity stationary cycling, certain brain regions have an improvement in connectivity. So we see some of that neuroplasticity in people as well. And the last thing I wanted to mention today is mindfulness. So mindfulness is essentially, I'm sure a lot of you have, heard of mindfulness. Mindfulness is essentially paying attention to the present moment without judgment. And it can be practiced in various ways, including in mind-body movement practices like yoga, qigong, tai chi, etc. It can also be practiced in the form of mindfulness meditation. And there's evidence that it improves depression and anxiety in Parkinson's disease. It may even improve motor symptoms and quality of life in Parkinson's, especially when practiced in the form of yoga. And in people with mild cognitive impairment, which is essentially cognitive changes that the person is complaining of, and there's also some evidence on objective testing in your doctor's office that there are some changes in your cognition, but it hasn't affected your function yet, so therefore it doesn't qualify to be diagnosed as dementia, that there is some evidence of the improvement in inflammatory markers in people with mild cognitive impairment. So you can think of mindfulness practices as sort of a brain exercise, like a bicep curl for your mind, so to speak. So I'll end there and I'll take any questions.
Thank you very much. I'm going to give folks a minute or two to type their questions in the chat box if they have any there. Or I guess if someone has a question and they'd like to unmute, they can do so and ask their questions.
No.
Hi,
Hi.
I'm having problem with the constipation, but
Mhm.
lately I've been taking quarter spoon of castor oil, and that has really helped me.
Yeah, okay, that's great. So yeah, so gastrolite, I think you're talking about essentially like it's almost like a bowel prep, right?
Yeah,
Yeah, so that is similar to PEG, actually. So it's similar to that, it's just it comes in a different form. So that's great. Thank you for sharing that.
We have
right.
a
Thank you
question.
kindly.
We have a question in the chat asking if you can just review the exercises that help with cognitive issues.
Yeah, so actually, a lot of exercises help with cognitive issues, right? So we know that moderate intensity and high intensity exercises definitely help with, and this is not just in Parkinson's, in general, in any kind of cognitive impairment. One of the things that we recommend is any form of exercise. So I would say that the best form of exercise is the form that you can stick to, that you like doing. Because we all know that it is hard to stick to an exercise routine. But in particular, I think the recommendations are 150 minutes of moderate to high intensity exercise, whether that's stationary cycling, or if your balance is better, you can do elliptical, or you can do Nordic pole walking and all that kind of stuff. That's all really good for you. Dancing is excellent, right? Dancing, because dancing engages a different kind of sort of process in your brain. It's you have to learn the moves, right? And these days there's also evidence that dual task exercise, which is some physiotherapists know how to do that, which is when you exercise you're also doing something else, like doing math or whatever, and that helps a lot with cognitive processing. And I would say that the reduction of anxiety, right, improvement of sleep, for instance, is also really important for your cognition, because we know that sleep is really important for people, and mood, low mood and anxiety can certainly impair your cognition as well. So I would say even exercises like yoga, qigong, Tai Chi, those mind-body modalities that are more, helpful for anxiety, for sleep, can also be helpful.
Thank you. And then someone in the chat is just clarifying 150 minutes per day or per week.
Yeah, 150 minutes per week.
Thank you.
But if you want to do more, then, by all means, go ahead.
I guess I will just add to that, if you're struggling to find an exercise group or you're wanting something that's Parkinson's specific, feel free to give our organization a call and we can let you know what's available in your community. There was also a question about watching this again, and so this webinar has been recorded and it will be uploaded on our YouTube channel if you'd want to watch it again, and we'll share that out with folks. This one I'm not sure if it kind of falls within the realm, but being that Lewy bodies are prevalent, what is the probability of developing Lewy body dementia?
So, yeah, we didn't quite have time to touch upon that, but essentially, the symptomatology, like the symptoms that people experience with Parkinson's disease, in terms of the non-motor symptoms, largely depends on where those Lewy bodies are in your body. Okay, so we know that about 50% of patients with Parkinson's tend to start to have cognitive changes by 5 years, and up to 80% can have cognitive changes by 8 to 10 years. So I think when you say Lewy body dementia, you're talking about dementia with Lewy bodies, because Lewy body dementia simply is the umbrella term we use to describe Parkinson's disease dementia as well as dementia with Lewy bodies, which are two different things. So there are some people with dementia with Lewy bodies that have cognitive symptoms pretty much right off the bat from the beginning when they develop their motor symptoms, or even before, okay, they develop their motor symptoms. So that's called dementia with Lewy bodies. Whereas when people have had long-standing Parkinson's disease and they develop dementia, then that's called Parkinson's disease dementia, and both these things are called Lewy body dementia.
Okay, thank you.
You're welcome.
Jumping back to exercise now, do you have any recommendations of options for people with mobility issues who can't work up a sweat, or maybe people who don't enjoy exercise and are struggling to get motivated?
Very good question. Okay, so so with mobility issues, there's chair exercise, right? So there's a lot of exercises you can do in a chair where you can actually work up a sweat. You can use resistance bands, you can do weights, you can do even dancing in a chair. Dancing with Parkinson's, which runs out of Toronto, has a free Zoom class every day, which you can sign up for. And, I'm always amazed at how much movement people can achieve sitting in a chair, right? And there's a lot of videos on YouTube as well from Parkinson Foundation, Fitness Friday, for instance, that has, a lot of chair exercises. So mobility issues is not a reason not to exercise, okay? And then if people don't like exercise, now, I think a lot of people don't like exercise, right? But I think, to form any habit, right, you need to be smart about your goals, as in your goal needs to be specific, measurable, achievable, right? You need to be kept accountable. So oftentimes when you sign up for a class, if you, as Emma was mentioning, there are local exercise groups. And if you sign up for an exercise group and people are expecting you to be there, there's a social component, right? Your instructor is expecting you to show up. That can keep you accountable, right? And I think, if you have, if you meet other people through your support groups, etc., or through, like venues like this, then, you can try and keep each other accountable. I think the accountability is really important. And try to, for instance, like when you make your goals, right? When we say specific and achievable, just try to make it small, right? And let's say if you're complete like non-exerciser at the moment, you do no exercise, right? You just sit there. So how about just for the first week, just say, well, I'm gonna go for 2 15-minute walks this week, right? And then by the end of the week, you would have achieved that. So that would make you feel good. Like, don't make huge and lofty goals from nothing, because then you will be discouraged if you don't achieve those. And generally, I think, the studies for habits is that if you do something for 3 weeks, then it will kind of become a habit. And in general, when people exercise, I have never heard anybody say, oh, I regret exercising, because after exercise, people always report feeling better. And in fact, a lot of patients, just for the motor benefit, they even report that after they take the levodopa, if they exercise relatively intensely, it can help them kind of their bodies turn on from the levodopa.
Interesting. Thank you. You're
You're welcome.
motivating us to exercise after this, after being seated for an hour.
Yeah.
There's also a request to repeat the laxative that could be taken with Restoralax and the probiotics.
Yeah, so that's Sanacot, Sanicides, Sanacot, which you can get over the counter.
Perfect, thank you. And then a question, if you could discuss what some of the cognitive issues could look like for people with Parkinson's.
Yeah, so the cognitive issues are quite different for Parkinson's compared to, let's say, Alzheimer's disease, right? So Alzheimer's disease is primarily the loss of short-term memory, meaning, people will forget what they ate for that morning. They'll forget appointments and things like that. Whereas for Parkinson's is more often to be what we call visual spatial or executive function or attention problems. So some people, they might start having visual hallucinations, or seeing shadows and things that are not there. And sometimes that can start with having visual illusions, meaning, you look at something and it doesn't quite look right. Like, let's say you look at a tree branch and it looks like a snake to you, or things look scroogey in your hallway or something, so that there's some visual spatial component. There's some fluctuations usually in the attention. So, some periods of time when people feel quite a bit sharper, and other times when they feel quite a bit out of it. And more insight, planning, organization, that type of thing. It tends to be the problem in Parkinson's.
Thank you. Okay, and we'll do the last one here. To help with constipation, does it help to sit on the toilet at around the same time every day to have a routine?
I think, in general, I wouldn't go sit on the toilet unless you feel like you have the urge to have a bowel movement, right? Because sitting on the toilet and trying to bear down will increase your chance of having a hemorrhoid. There's something called the squatty potty that one of my colleagues, Dr. Miyazaki, likes to recommend quite a bit. So I don't know if Emma, can you call up a picture of squatty potty and maybe share it? I can't hear you, Emma.
Yes, sorry, I was just pulling it up.
Okay. So squatty potty essentially helps people. Yeah, it's like a thing to raise your feet when you're sitting on the toilet, and it helps people have a little bit of a easier time having a bowel movement, just because of the physiologic, like the intestine is kind of like in a more physiologic conformation, if you would. Okay. And yeah, so in general, I find that a lot of people tend to have a cup of coffee or a cup of hot tea in the morning. Having a larger volume breakfast with a cup of something warm and doing some exercise in the morning usually triggers that urge to use the bowel, to have a bowel movement.
Is it possible people wouldn't feel that urge?
Yes, it is. It is. If there's significant, uh, uh, dysfunction in your gastrointestinal tract, right, then yes, people can have the lack of urge to poo. And so, if that is a significant issue, which is, not uncommon in more advanced Parkinson's disease, that is when people need that stimulation, which is the role of the stimulant laxatives, like I mentioned, right? Because no matter how much fiber or Restoralax or PEG, you take, it's not going to necessarily give you the urge. And some of the patients even need suppositories right? And so if people end up using Senecot every single day, right, and it's still not really working at higher doses, some people might need to switch to suppository to actually have that urge to use the washroom.
Right, thank you. We'll wrap up here then. I don't see any other questions in the chat. Thank you so much, Dr. Lee, for coming and taking the time to join us and share your knowledge. And thank you to everyone who was able to attend live and share your questions. Like I mentioned, the webinar will be recorded and added onto our YouTube channel, so you can check it out there if you'd like to. And then our next webinar will be available here and on YouTube as well. And you can check our website for the date and the topic of that one. So thank you so much, everyone.